Inspired Hygiene has been around for about 15 years, and we have been able to have the opportunity to work with practices all over the country, whether it's an individual solo, practitioner, or a multi-dentist group, or multiple locations. And so our experience with DSOs has been, like I said, with small groups, but also with some larger groups doing pilot programs, doing some CE programs for them, and that kind of thing to really help move the needle with hygiene. And what we're going to talk about today is really how to expand that conversation within the hygiene department around the oral systemic link, why that matters, and how that can help you really get the hygienist's attention and help them really believe that the care that they're providing makes a big impact on their patients' overall health. Because what we have found in coaching hundreds of hygienists all over the country is, as dental professionals, we all have a heart for our patients, right? We wanted to do this because we can make a difference and we can really interact and be an important part of our patients' lives. And so sometimes there are obstacles that get in the way. We'll talk about that just a little bit, but if we can really, regularly center on that and really regularly look at the impact that we have the opportunity to make with our patients, that helps us move through some of those obstacles, right? It helps us stay the course and presenting the treatment that we feel is in our patient's best interest, even when we face objections from patients, maybe when the schedule's kind of crazy and messy, or when, unpredictable things happen, like, have been happening lately in our world. So I just want to start with this little quote that I heard a while back: disruption forces us to evaluate what we believe. So man, 2020 was a disruption to say the least, right? And we clearly saw a lot of dental professionals evaluating what they believe. We have some clients who lost 4 out of 5 hygienists for various reasons, and some who were fortunate enough to maintain their entire team. And I'm sure that all of you have experienced a range of this across your locations. I heard this quote a couple years ago, and it also reminded me of the work that we do at Inspired Hygiene as coaches and consultants. And it might remind you of what you experience, particularly the leadership team and the groups, when you acquire a practice and you need to calibrate that team to your organization's standards, right? So while most of our clients are very pleasant and we win them over as lifelong colleagues and friends, in the beginning of our engagement with them, sometimes we are seen as a disruption, right? Why are we here? Everything's working fine. You might notice that, you might have experienced that maybe with some of the acquisitions, as everything was working just fine until you guys showed up, right? And then you decided to shake things up quite a bit for us. And so we absolutely ask those that we work with, our clients, to evaluate what they believe as we're coaching them. And we help them work through that. It's important to allow them to express, those concerns, those challenges, those internal struggles that they're feeling, in order for us to help them get to the next place. So, during the shutdown, we saw some dental professionals evaluate their beliefs and decide to leave the profession. For, again, various reasons. And then some, we noticed, became even more committed than ever to their role as healthcare providers. And I really believe that to step more fully into our role as healthcare providers, we have to evaluate what we believe continually, right? We've got to look at the science. We've got to look at new developments in our industry and in the care that we can provide. And then we've got to communicate those beliefs with our team, right? Talk to them, talk about those beliefs and how things are shifting, amongst the team and also with our patients. So this is a team that we've worked with several times over the past few years in Georgia, and I just love this illustration because it reminds us, it takes us back to, March and April, when we were not able to be with patients, and how teams adapted, and how they communicated with each other and with patients in the midst of this enormous disruption. And it was really heartwarming to see them come together like this to stay in touch, and then to take their practice culture, right? This team is a very warm, friendly, just kind of hometown practice, and they wanted to maintain that practice culture, and look at how they did that, going all the way to Christmas and still saying, hey, we're smiling at you behind our masks. we are putting in place these additional precautions to make sure everybody stays well and that patients feel comfortable coming back. I think this is just a great way to illustrate how they stood firm in their beliefs in patient care, but evolved, right, as we're all dealing with these different things. And then, you know, what about this? This is Dr. Ryan Thrower in Oregon, the first dentist to give the COVID vaccine. I mean, talk about evaluating our beliefs. And now here we are with dentists in some states giving COVID vaccines. Hopefully that will expand to hygienists as well. I know many of you probably with your groups are evaluating, you know, do we do this? Is this an opportunity we step into? And, you know, I will say on social media, I saw some debates around this going around and some people saying, you know what, we just need to stay in our lane and we don't need to get involved with this. But my feeling is, you know, we've been trying to bridge this gap between dentistry and medicine for years, right? Those of us that really feel strongly about this oral systemic link. And this is an opportunity, I think, to close that gap. Certainly there are lots of things to consider from regulatory pieces of this that you all are way more familiar with than I am. But I just think from a standpoint of presenting ourselves to our patients in the community, there's an opportunity here. And so some of you might be looking at that and trying to decide, you know, whether or not to participate in this. And then I thought, well, what about when general dentists started doing surgical procedures? Or when general dentists started placing implants? You know, there probably were people that said, stay in your lane, right? But what it did was it expanded access to care, right? It expanded the opportunities in the practice. It expanded education, not only for the dentist and the team, but also for patients. So I think that there's just a lot of different ways we can look at this and, you know, just make a decision from that perspective. And I've always said, if we want to be seen as healthcare providers, we have to act like it and we have to step into that role. And our patients are not going to come to that conclusion on their own. It's really up to each individual dental professional to step into that role, to step out of our comfort zone, right, from the scale and polish to really talking to our patients more about the oral systemic link. So I'm going to give you some resources for that today. And again, this dentist certainly made that big leap in her role as healthcare provider. And there's no better time to have these consistent and elevated conversations about this with each other and with our patients than now. So this was a book that I read several years ago by two brothers, Chip and Dan Heath, and it's called Switch. We'll get there. There we go. So it's called Switch, and it's all about how to make change stick, how to implement things and keep them in place, right? Because there's nothing more frustrating than, you know, developing an initiative and going into the practice and educating our patients, or educating our team rather, and then all of a sudden you go back 3 or 4 months later and things are kind of back where they were. So they talk about this concept that our minds are really ruled by two different systems, the rational mind and the emotional mind. And they go on to say that these two parts of us are constantly competing for control. And they use this example of an elephant in a rider, right? And what they share with us is the rider is actually the rational mind. This is our piece of us that reads the research, right? That, like we'll do in just a minute, and evaluates it and says, okay, I understand that. I understand that periodontal disease can be a contributing risk factor to cancer and heart attack and stroke and all these other conditions. And then the elephant actually is the emotional mind, right? And the emotional mind really is in control. You notice how much bigger the elephant is than the human, all right? So the emotional mind really is in control. So as educators and leaders, this applies to leading dental teams. It also applies to patient care, right? Communicating with patients is, if we're only appealing to that rational mind, then we're missing a big chunk of how to shift behavior, right? We've got to also address the emotional mind. And then there's a third aspect that they say that has to be in alignment in order for change to stick, and that is this path that this elephant is walking on, right? And that is our situation. That might be the schedule. It might be the amount of time that the hygienists have for each patient. It might be hygienist-doctor relationships. It might be equipment limitations, right? There can be all kinds of things that come up that make this path smooth, right? So that when the emotional and the rational mind are on track and together, that makes this work really well. And there also can be a number of obstacles that can get in the way of moving forward on this. And what I found is when we don't address those obstacles and we just kind of give a directive of the way things need to be, that this elephant and the rider usually turn around and go right back to that comfort zone of where they were before. So it's really important to address those beliefs. And what we have found over and over with our clients is that, you know, if there is a struggle on the inside, if that really strong belief is not there, then the hygienists have a hard time moving forward. So when there's a struggle on the inside, it always creates a struggle on the outside. So we've got to make sure that we have a really strong why that focuses on diagnosis, treatment, and overall patient health. And what we found is when we can do that, our clients can be extremely successful in increasing their level of care. The example I like to use here is think about fluoride. And consultants are really guilty of this. Maybe you guys can relate to this to say, okay, so we've set this hygiene production goal. And you know, we're not far off. We're doing a good job getting to the goal. But you guys, if we could do 3 more fluoride treatments a month, then I'm sorry, 3 more fluoride treatments a day, then we'd get to our goal, right? So that's our directive, and we just say, like, how easy is that, right? 3 more fluoride treatments a day, and you're going to hit their goal. But if we start by presenting this opportunity and presenting the service from a production standpoint, then the hygienist might get it, that might say, yeah, okay, that makes sense, maybe I can do that. But it tends to not last, right? Because they're going to get some objections from patients, right? Maybe they don't have really clear and specific verbiage around that they've had an opportunity to practice and get comfortable with. And so they might believe it on the outside that, yeah, I see that, I just need to do 3 more fluoride therapies. But on the inside, if they're not feeling that that treatment is in the patient's best interest and that the patient is getting more value from that treatment than the cost of it, then they're often going to struggle. And what we find is things just don't stay in place. So if you find that there are certain initiatives or things that you're trying to roll out, be sure that you have really addressed not only, you know, the rational mind, the intellectual mind of why does this make sense and why are we doing this for the business and for our patients, but also make sure you've addressed, does the team member that's executing on that, that's implementing that initiative, have an opportunity to really talk about their beliefs? Because that emotional mind is a lot stronger than we believe it to be. It really is, and it can really make or break any type of efforts that we're trying to achieve and anything we're trying to implement. So, you know, talk about why is this in our patient's best interest? What are some of your concerns? What are some of the things that you see that are benefits to patients with this? And then really that can help them move through some of those obstacles. So in the objectives, we talked about a plan to refocus. So let's get to that. Bill, maybe you could click through for me. That might make it a little bit faster here. There we go. Awesome. Thank you. So the first step, and you all know this, I don't have to tell you that it has been rough, right? The last year, you're living it every day. And I would just say, be sure your team knows that you appreciate them and make it really specific and make it personal. Acknowledgement is super important to help anybody move through a difficult time, right? It's just acknowledging the work, acknowledging the commitment, acknowledging the effort. And I'm going to give you a resource in just a minute that is a short video that I did that really is helping to lead hygienists out of what I'm calling this dark tunnel. And what we noticed over the last year is even some teams that had a really solid plan for diagnosing, treating, you know, enrolling patients in periotherapy. They had blocks on their schedule, like they were just doing a great job of it and things were moving right along. You know, when they came back, things were so different. things were so different. Their schedule was jam-packed. They were trying to get all these patients in, and very often they just kind of put all of that to the side and just said, we've got to get caught up, right? So all of a sudden the blocks went away. They didn't have anywhere to put patients for periotherapy. So they were maybe shortening patient appointments too, or maybe they just didn't have as much time in the appointment because of all of the COVID screenings and things like that. And for whatever reason, some of their systems fell out. And so they ended up back into this dark tunnel of prophys, right? One prophy after another. So now we're helping them pull out of that, right? And that is this plan to refocus on high-level care. And these are the steps that we'll go through today, right? First thing is acknowledge the team for what they're doing. Next is establishing the difference between health versus disease. And I'll give you some really clear ways to do that. Determine what is the potential. I mean, we're talking about oral systemic link and perio here for the most part. But what is the potential to care for patients in our practice today? We'll talk about that. And what is the impact that we can make? I'm going to give you an exercise to really help, actually a couple exercises to help the hygienists really discover for themselves what is the potential for care here and what is the potential impact that we can make. And then we'll come back to this and talk a little bit about your standards of care and some goals. So yeah, let's hit the next slide, please. All right, so this is from the AAP's World Workshop, where they established that new, staging and grading system. So if you go on to that webpage, it's linked from the AAP, perio.org. It's linked from there. There's tons of documents there, right? There's all these papers that came out of that World Workshop. And remember, this was a collaboration between the American Academy of Periodontology and the European Federation of Periodontology. So they came together and said, okay, what do we know about periodontal disease? How are we going to create this new classification system? And this is one paper that I found really interesting was, a lot of times we really are only looking at the diagnosis of disease, but what about health? Right? What constitutes health? And I will say that what I have seen across the country, and you guys see this because you're working with multiple locations and lots of different providers, is there is very little consistency in our industry between what is considered health and what is considered disease and when intervention is necessary, right? You'll probably even see that within your locations, within one location, even when you have multiple hygienists, multiple dentists, right? One provider can look at a patient and come up with a completely different treatment plan. So one of your charges is to help calibrate those providers. And this is something that we do with hygienists all the time. It's something that we also help when there are multiple dentists in the practices. How do we start to calibrate our restorative philosophy so that the hygienist can support them, right? So it's really important first to get calibrated on what is periodontal health. And so this is just a piece of the introduction that stood out for me is the absence of inflammation associated with gingivitis or periodontitis assessed clinically is a prerequisite for defining periodontal health. So a patient cannot be considered periodontally healthy unless there is an absence of inflammation, which is associated with gingivitis or periodontitis, right? And what is our our primary indicator of active disease, right? It's bleeding. Okay, we're going to talk a little bit more about bleeding in a moment. So if we're seeing bleeding, if we're seeing inflammation and swelling, if we're seeing indications of active infection there, then that patient is not healthy. And so the reason why this is so important is just that we look at our different procedures, right? We look at a prophy. So why do we have patients that are not periodontal healthy, being treated with a prophy? Are there other more appropriate treatment recommendations for them and procedures that can help move them into that health? So the other piece of this that's really interesting is that there are patients that can move, obviously, from active periodontal disease to a state of health. But you probably can't see this, but it's in this gray box, and you'll see it. I encourage you to go grab this paper. There is a classification that is periodontal disease with a reduced periodontium, right? So sometimes we get questions about, well, what about patients that have bone loss from past periodontal disease or other reasons, but they're healthy, do they need periotherapy? So there is such a thing as a patient being healthy, but they've had a reduced periodontium. So just really, this is the first thing to focus on, is what is health, all right? So the next thing is, what is disease? This is a really simple table just to summarize the AAP staging and grading. Aziza is actually going to present a table that she created that is really detailed and awesome, that she uses in her organization. So make sure you pay really close attention to that as well. But this is a really clear summary of the staging and grading, so you can look with your hygienist first at, okay, this is health. Now here we are with disease, right? And the AAP is saying that stage 1, right, is this stage 1 disease, is this mild periodontitis. And we're seeing less than or equal to 4 millimeters in pocket depth. All of these levels of periodontitis have bleeding in common, right? There is bone loss. There's a minimal amount, but there is bone loss present. So then the next step is to really help the hygienist self-identify, you know, what is the prevalence of periodontitis in our practice? So if we look at what the AAP says, is that 47% of Americans have some level of gum disease, right? Mild, moderate, severe. And the CDC, I looked this up recently, the CDC says the exact same thing. So 47% of Americans have some level of periodontitis. Now, you know, a lot of you are tracking your perio percentage. That's something that we track with our clients as well. And so, you know, are 47% of your patients in some type of perio therapy plan? Probably not. That's a pretty high number, right? Some of you may have practices that are at that level, but that's okay. We can get there, or even if we get close, we recognize that we're actually, you know, really focusing on treating this disease. So here's how we help hygienists really self-examine this. If we look at health and then we look at disease, we ask them this question. If you were to think about your adult new patients, so adult new patients that are coming into your practice through a comp exam, and some of you doctors might see the patients first. So doctors, this is a question for you. Hygienists might see the patients first. Whoever's seeing that patient clinically, what percentage of those adults coming in for a comp exam have active bleeding? They've had horizontal or vertical bone loss, and they have pocket depths that are 4 millimeters or deeper, okay? And so those of you that are seeing patients clinically, maybe take a second and write that down, right? What is the percentage of the patients you see, new adult patients in a comp exam, that have bleeding, bone loss, 4 millimeter pocket depths or deeper, okay? And then the next question is, what percentage of your patients that you see for perio maintenance or prophy, right? So these are existing patients. What percentage of your patients in either of those categories fall into this area of disease, right? What percentage of them have bleeding, bone loss, 4 millimeter pocket depths or greater? And have them answer these questions, right? So what we find is that most hygienists will say at least 50%, right? At least 50% of our adult new patients that come in have some level of disease, okay? So then we can look at a potential based on that. All right, so if we see 40 new patients a month and half of those adults have some level of disease, that's 20 patients. And then you can determine what's the most common number of quads of therapy we do on those new patients. I'd say most new patients, it's 4 quads, right? So what's the math on that, right? If you're seeing 20 patients a month that have disease, and we on average do 4 quads on those new patients of therapy, right? 20 times 4, all of a sudden you're at 80 quads of therapy, and compare that to what's currently being performed. So this is a really great way to have hygienists kind of discover, wow, there's a lot of potential for care here. We might want to be looking at these patients a little bit closer. And then often the question is, okay, so we have this disease in our practice. What do we do about it, right? How do we enroll these patients in treatment? What is our plan of action? And how are we gonna move them through care? The next question about existing patients is often a little stickier, right? It's a lot easier to present treatment to new patients who we don't have a background with, right? I mean, we've got to develop trust and that kind of thing, but we don't have all the baggage that sometimes we bring with us with existing patients, right? We know their ins and outs. We know their sister, is having problems, or their husband's in the hospital, or whatever it might be. And so sometimes we hold back on those recommendations for fear of overwhelming patients. And it's because we care, right? It's not because we want to neglect anything. We're care and concerned. But remember, it's always our patient. The patient should have the right to say yes or no to treatment. So same thing now, if we're moving into these existing patients that are in prophys, perio maintenance, what percentage of those patients have active disease? And it's not uncommon for some hygienists to say 75%. 75%. And then we say, okay, so what if we're talking about they have more than one, maybe if we pull out, okay, they have 1 4-millimeter bleeding pocket, and we make it a little bit more reasonable and say, okay, so if we're talking about multiple areas of bleeding, bone loss, 4 millimeters of pocket depth or deeper, then maybe we're at 45%, right? Or some demographics, they might say, you know what, that's really maybe 15%. Wherever you might be, it's really important to have the provider share their perception rather than us saying, hey, we've run the numbers and we're at 10% perio, and based on what the AAP says, we should be at 40%, or based on what Inspired Hygiene says, we should be at 35%. That's not going to resonate real well with the hygienist when they're seeing it every day and thinking, there's no way. But when we really look at that and we really look at the belief between what is health and what is disease, we give them an opportunity to discover this themselves, and then it opens a whole nother door. And then you can run the numbers on that. You can look at the potential with existing patients, right? Now, you might have more of a likelihood with existing patients that they have localized disease. So maybe it's 2 quads, right? You can look at the number of patients that hygiene sees every year or every month in recare. And then we look at, what's the percentage that we feel of those patients that have disease, and then be conservative, right? Be conservative with that. And then if we did 2 quads on each of those patients of localized therapy, what would that be? And then take those potential numbers and compare that to what you're actually performing. And you might be doing great, right? We might say, we're right on target. Or we might say, we've got a lot of opportunity to grow in this area. So this is one self-discovery exercise that really works very well. So now let's talk about the oral systemic link, okay? There is an enormous body of research, multiple systematic reviews of the literature, joint meetings of the AAP and the EFP, and they all, for the most part, come to the same conclusion, that there is a link between periodontal inflammation and multiple other adverse health conditions, right? We're learning more and more from our medical colleagues that inflammation is a key risk factor for almost every disease there is, right? Whether it's autoimmune or diabetes or heart disease or whatever it is. And, we all know periodontal disease is an active infection, active inflammation in the body. So there are even some studies that show a causal relationship between periodontal disease and risk of certain health conditions. It's out there. And I am not comfortable as a hygienist telling my patient, hey, this might cause X, but I'm very comfortable saying this could increase your risk for X, especially when you have these other multiple risk factors. Okay, we're going to talk about how do we connect that with our patients? How do we connect those dots? So there are a lot of studies also that have found periopathogens in other areas of the body, in joints, in the uterus, in the carotid artery. We're going to look at one of those in just a minute. So in my opinion, it's pretty undeniable. And this is what we've seen to help shape that belief that we can have an impact on our patients' overall health, and that inaction can have a negative impact on their health. So, we talk about, remember, that rational mind and the emotional mind. This is what we're really getting into. So the first step is we're identifying what is health versus disease and what that disease prevalence may be in our patient population. And now we're looking at, okay, so how do we address that? And certainly you know, this is something we work with clients on, or is the logistics of how do patients flow through the care, you know, from prophy to periotherapy to perio maintenance. What are the adjuncts we use, that kind of thing. But before we even get there, and before we even set any goals, you noticed on that plan, the goals were last, right? Before we set any goals for production, or before we set any goals for number of quads, we've got to address this belief. So one of the exercises that we do every time, I've done this a lot, if any of you have heard me speak on this perio piece, you may have been a part of this. We do this with all of our clients, and I'm going to give you guys the resource for this, is a research review exercise. And this is really how we bring this to light. So again, instead of me, right, standing up in front of a group, or one of our coaches standing in front of a client and saying, hey, you guys, you've got to treat periodontal disease on a much higher level because it affects, you know, their risk for this and this and this. Let's let the team experience this for themselves. Let's let them discover this for themselves. So in the resource page, and there are going to be multiple ways for you to get that, but it's going to come with your CE. At the very end of it, there's an outline for how to do this exercise with your team. So let's look at one of these studies, and I'll kind of walk you through that. All right, so, and you have links to these in the research page, so don't worry about like trying to scribble this down or take a picture. You're going to have a link to the abstract of these articles in that, so you can use this as a resource. So this is a really interesting article, Chronic Periodontitis and the Incidence of Head and Neck Squamous Cell Carcinoma. So this was over 500 patients, right? Or nearly 500 patients over about 6 years. And part of those patients were in a control group that did not have a malignancy, and the other part did have a malignant head and neck squamous cell, you know, lesion. They had been diagnosed with that. They had an examiner that was looking at Panorex X-rays. They did not know who was the patient with the cancer versus who was the control. They did not know that. That part of the study was blinded, and they measured alveolar bone loss. And what they found was, when they put these things together, was that each millimeter of alveolar bone loss was associated with a greater than 4-fold increased risk of head and neck squamous cell carcinoma. That's pretty significant, right? And then we'll look at another study on different types of cancers in just a second. But with this research review, what you do is you pull out several, let's say you've got a group of 20 hygienists or 20 hygienists and dentists. This is great to do with the entire team, because it's just as important, right, for your assistants and your business team to have these beliefs as well, right? They're going to be backing up the treatment that the hygienists and dentists are recommending. So bring everybody together. Let's say you've got 20 people, break them up into 4 groups of 5, and you have 4 different research abstracts, right? You print out a few copies of each, give it to the group, have them read it together. Each group is going to read theirs silently together, and then they're going to have like a whiteboard or a big sticky note page, and they're going to be writing on there, what are the 1 or 2 things that were really surprising to us about this article? What did we learn that was new? What can we share with our colleagues, and what can we share with our patients? Okay, so have them do that exercise, then they're discovering it, and then have a spokesperson from each of that group stand up in front of the group and say, hey, this was the title of our article, and here were the 2 things that we really pulled out of this. And then as the facilitator, it's really important, if you're the facilitator, to recognize what you find important about this article. Be sure you're familiar with it, you've read it. If there's anything that the team didn't bring out, make sure you bring that to light. And then all of a sudden, it just creates this great dialogue, right? This can also spin off into a dialogue about oral cancer screening, right? Why is it so important for the hygienist and the dentist to both do an intraoral oral cancer screening? Why is it important for the hygienist to do an extraoral cancer screening? Okay, because we're seeing that there is such this connection between periodontitis and this head and neck cancer. So just a great example of how to use that research review. Here's another one. Another one is periodontal disease linked to the development of different kinds of colorectal cancer. I thought this was really interesting. There have been multiple studies on the connection between periodontal disease and pancreatic cancer. And this article highlights a couple of those. One was done recently, one was done more than a decade ago. But the one study, the more recent study, found that P. gingivalis, right, that periodontal pathogen, was associated with a 59% increased risk for pancreatic cancer. And then another type of bacteria, AA, which we know as being a pretty dangerous pathogen. AA has also been associated with brain abscesses. It is kind of in a category of its own within the pathogen profile that we see with the different pathogen complexes. AA was associated with over a 100% increased risk in pancreatic cancer. Now, this can take us down a whole nother track that some of you have probably gone down with regards to salivary testing and identifying some of these pathogens that are there and what are our treatment options for these. But it's just really important to be aware of this connection. And again, just another great study for that research review exercise. This is really interesting. This is actually two studies where we learn that periodontal pathogens have actually been seen in the coronary artery plaque. So two different studies. One study found that there were periodontal pathogens present in 92% of the pathogens in the plaque. So this was done through carotid, sorry, I always had a hard time saying this, carotid endarterectomy, right? Study one, 92% of those plaques that they pulled out of the carotid artery had periodontal pathogens in it. 64% had 2 or more periodontal pathogens in it, okay? Now we have this second study, and in this study, same thing, carotid endarterectomy, they pull plaque out of the carotid artery, they test it and see what's in there. 100% had at least one periodontal pathogen in the plaque, okay? So how do those things get there, right? We know that these periodontal pathogens travel to all these other places in the body. There are studies showing it in synovial fluid and joints, right? Many of you might be aware of, there was an incident at Case Western, they studied of a stillbirth, and it was tracked back to a periodontal pathogen that was in the uterus, right? And that was a causal agent of that stillbirth. So the way they get in there, right, is through this ulcerated epithelium, right? And whether we see bleeding on the right, which is very minimal, but it's still there, or we see this on the left, that indicates that that lining of the sulcus is ulcerated, and that bacteria can travel in and out of the bloodstream at will. And the other piece of this slide that I love so much is it just really prompts us to the power of intral photos. So most of you are really comfortable and probably take a lot of intral photos of teeth and restorative needs and educating patients in that regard. I really encourage you to do the same with periodontal disease, right? Because there's no denying this, that there's a problem here, right? Now, obviously it's a little bit more subtle here on the right, and it's really difficult to use an intral camera while you have the probe subgingivally. This is obviously this operator had some help here taking this photo. But again, these are things that can really help make your case with yourself, right? You take a picture of this and say, well, I can't deny that. There's a problem here. We need to recommend some type of therapy. Also, really educating the patient, showing them what's going on, because the patients aren't going to be able to see this with a mirror usually. And also making your case with third-party payers, right? So that you are verifying and you are supporting your claim that there's active infection here that is requiring treatment. So just take this as an example. These studies, there's more in that resource guide, and the outline for that exercise is all there. And I really just encourage you to take this because it will expand that oral systemic conversation within the practice. Okay, this is another just image of some great resources. I really believe in third-party resources for educating patients, whether that is a video program that you use to educate patients on periodontal disease and different procedures in the practice, or whether they are laminated tools like this. So the one on the lower left obviously came from the American Heart Association. This is another just area that hygienists have the opportunity to make a huge impact on patients' overall wellness is blood pressure screening. And I know a lot of you are doing that. Just make sure that you find a way to make that easy. We recommend the wrist cuffs. There's a brand called Omron that most of you are familiar with, and I have tested that multiple times against a pulse oximeter, blood pressure cuff, and found it to be very accurate. Certainly they're technique sensitive. But the point of this is a really great guide to have, chairside. This is something that we use with patients. A lot of our clients use this to say, hey, you're in this point where you're in this orange range, and so we're going to ask you to see your physician as soon as possible. We're really concerned about you. Also, if you have a threshold, and this will come up when we talk about standards of care, if you have a threshold for when you are not going to provide care because of blood pressure, having this as a third-party reference is really going to help you overcome provider and also patient objections if that ever becomes the case. So that is on the American Heart Association website, blood pressure categories, really great tool to have. All these other images, these infographics that are so fantastic, came from an organization called AOSH. And I know that most of you are probably familiar with AOSH, the Academy of Oral Systemic Health. It is a member organization, and the membership is very affordable. Inspired Hygiene is a member of AOSH, and part of that membership is access to some incredible CE opportunities about the oral systemic link, really taking it to the next level, and also access to these types of tools. And these are PDF downloads that you can use, and then you can print as many of these as you like, whether you would like for this to be a handout for patients, whether you want to laminate this and have it chairside as educational material. There are just a ton of these resources there, and I just really wanted to share that with you all and let you know about that and to take advantage of that. It's a really great resource. So how do we tie all this into the conversations that we have with our patients? We have a framework that we teach for presenting periotherapy and also presenting restorative therapy too. It actually works quite well with that. And it goes something like this, right? So we have done the complete diagnosis, collected all of our data for the patient. We know what their state of health versus disease is, right? And if this is a patient that has active disease, right, it's really important to let them know what's going on so that they can make choices about their own health care. So, for example, we might say something like, based on what we've seen during the exam today, you have active infection. The good news is it's localized to these areas. I'm concerned because, I'm going to come back to that, and we recommend, okay? So the I'm concerned piece is the perfect place to tie in this oral systemic connection. So I'm concerned because I know you've also really been struggling with controlling your blood sugar levels and getting your diabetes under control. And what we know is that this type of infection, right, this gum infection, and where you're having active inflammation in your gums and the bone that support the teeth, absolutely is connected to diabetes, and it makes it much more difficult to control the blood sugar levels. In fact, we've seen that relationship that if blood sugar levels aren't controlled, very often people will have a higher risk for more infection in their gums as well. So this I'm concerned is a really great bridge between the treatment that you're recommending and what's already happening with the patient. Now, what if they don't have any health conditions, right? How do we use this then? Well, let's say they're a really health aware patient and they take really great care of themselves and they've been very fortunate to not have any kind of medical concerns up to this point. You can say, I'm concerned because I know that your health is very important to you. And what I also know is this type of active infection can put you at risk for other health problems in the future. So this is a great, really simple way to really tie that in. And remember how important that having the intellectual mind and the emotional mind aligned are. The same is true for our patients, right? So we can talk to them all day and tell them what we recommend, and yet if we don't tie this in somehow with them emotionally, it's just not going to land quite as strongly. And it's really important also to communicate this with the dentist, right? So if the hygienist is presenting this, right, and we typically say at the end, we recommend, and doctor will come in and confirm all of this, right? Because doctor makes that final diagnosis. Then we can share with doctor, I'm concerned, right? I'm concerned because, you know, I know Bill also has, he told me he has a family history of diabetes, and we've been tracking this bleeding and it's not getting any better. I believe it's time to do something different. And I'm concerned because of that family history of diabetes and the amount of bleeding that I'm seeing, that there could be a connection there. I'm also concerned because I know he's being treated for high blood pressure and high cholesterol. And this type of infection is also a risk factor for heart attack and stroke. So we don't have to make it super elaborate. We don't have to make it super dramatic and freak the patient out, but it is important to connect that so that they can understand that, and they know how those things are connected. The other piece of this is, the more that we speak about the oral systemic link and we bring our patients alongside us with that, right? The more we are closely looking at their medical history and really thinking about what we're seeing there, then the more our patients will see us as a healthcare provider, right? So we want to change our image as hygienists from our patients seeing us as the mouth maid, right? We hate that. We don't want to be known as that. Then it's up to us to change that perception and really helping our patients connect the dots on, why do we care what medications they're taking, right? What does this have to do with my mouth? So that's really up to us, right? So, you know, maybe instead of us feeling like that, we have to get defensive, because I know I've been there. Instead, really thinking of it as an opportunity. You know what, that's a really great question. And I can understand why you would wonder, why are we asking you what medications you're taking when you're here to, you know, have a filling, or you're here to, you know, see me, you know, for your preventive visit. And here's why. You know, what we know is that the majority of prescription medications cause dry mouth. Dry mouth can cause lots of other problems, put you at higher risk for, you know, decay around your teeth and the dental work that you've already had done. What we also know is that gum infection can be related to other types of health problems. So it's really important that we have a good idea so that we can really be, you know, do the best that we can for you and your care. And so when you see things like arthritis on the medical history, what else could be going on, right? What type of arthritis is it? Maybe consider adding to your medical history some questions about family history, right? And Aziza is going to talk about this too. She's going to talk about the comprehensive exam and what's included in that, and why that is so important as a pillar of your organization overall. All right, so now let's go back and let's look at, you know, we've gone through this whole presentation piece, right? We've identified the disease. Now we're presenting it. So, you know, what about treating the disease? Now, we are super fortunate that we have a lot of adjuncts, right? And we have a lot of tools in our tool belt for adding to non-surgical therapy. So look at all these options, right? Our scaling root planing, surgical intervention, laser therapy, local and systemic antibiotic therapy, subgingival biofilm disruption with, you know, subgingival air polishing with glycine, and then hydrogen peroxide therapy is one therapy that has really emerged over the last, I would say, 5 years in our industry. And one of the things that we notice about some of these other therapies is that there's a limitation on the amount of time that they are effective, right? And what we know is that as soon as that patient walks out the door, that those pathogens start to repopulate, right? And that patient is slowly moving back towards that disease state. That's why we have them come in so frequently for perio maintenance. And that's why we want to make sure that they're doing their home care appropriately and all of that. So one of the great things about this hydrogen peroxide therapy, and Mike is going to talk to you in a little more detail about Perio Restore, which is a therapy that DenMat has now that they're offering. It is a fantastic tray delivery system with custom trays for the patient that actually push that hydrogen peroxide down into the sulcus, right? So now our patients have a way to control those pathogens indefinitely. Now, A lot of you may be familiar with this and say, yeah, there's a compliance issue with that, but here's some good news. We've got some studies about this hydrogen peroxide therapy, and one of the studies I'm going to share with you, and you have a link to this in the resource guide as well, is this top study about these 66 refractory maintenance patients. So these were patients that were unresponsive to scaling root planing and were sliding back right into the state of losing bone and having active inflammation. And what they found was this hydrogen peroxide tray therapy was very effective for them. And the good news is that the patients that used it once a day had just as good of a result as those that used it twice a day. So now compliance becomes less of a concern, right? If we can get our patients to do this once a day, maybe they do it when they're in their shower, right? They do it in the shower for 15 or 20 minutes. Maybe they do it in the evening when they're watching TV. Whatever it fits into their routine, right? As hygienists, we're used to figuring out how home care can fit into a patient's routine. They can really get a lot of great benefits from this. The next study is custom tray application. They compared scaling root planing alone as compared with scaling and root planing with tray therapy, and saw a dramatic reduction in pocket depths and bleeding compared to the scaling and root planing patients alone. So we can see here that using it right off the bat, even before scaling root planing, can really make a big difference in the patient's response to that. And then they have these trays to continue using so that they're keeping those pathogens levels down, which keeps the bleeding down, which we know means that the inflammation is down, which reduces, their risk for these other adverse health conditions. And the cool thing about peroxide is there's no allergies, it's safe with implants, it's really easy to use, and it's just really effective. So let's go back to our plan, okay? We're talking about refocusing here. All right, so acknowledging, we've looked at how do we establish health versus disease. Your potential is where you're doing some math and looking at if this is the number of patients we're seeing, how many quads would that translate to? What is the impact, right, that we can have on our patients' overall health by doing this research review and really opening their eyes to this oral systemic link? And now let's talk a little bit about standards of care. So I'm going to give you a resource in just a second where you can get this document. So this is a several-page document that you can use to really work with the team to bring everybody together so that you have the same standard of care. And I believe that it's really important to allow the clinical team to have some input, right? To have some input on this. Even if you, as the leader, know what you expect your standards of care to be, and you know what you expect from a standpoint of diagnostics, right? How often are we doing a complete periodontal charting? What does that include? It's still good to allow them to have some input, to have some discussion, to talk about their beliefs around these pieces of diagnosis, and to also hear what some of the obstacles may be, right? So this is a really great tool that you can use in any kind of team meeting where you want to just really reinforce and reestablish and calibrate these standards of care. And this goes into talking about, as you can see, this is the first page, how often are we doing perio charting? What does that include? What about radiographs? How often are we doing a health history update? When are we doing blood pressure screening? And at what point with blood pressure will we send our patients directly to their physician and postpone care? There's a link to that hypertension resource there. And then this just goes on for several pages of, okay, when we see this, then we will move our patients from a prophy into periotherapy. And also remember too, a lot of times, particularly if you have done some work on your perio protocol and you've put that in place and you've made some good progress on that, what happens sometimes is patients get stuck then in perio maintenance. So be sure in the standard of care that you're also addressing, what happens with patients in perio maintenance? How do we move them back into active care? What adjuncts do we have to help those patients stay healthy for the long term? And when do we make referral recommendations and all of those different things that really the team needs to know to keep them all on track? This is a great way to calibrate your hygiene team and also doctors and get everyone on the same page. Some offices keep a copy of this hung in a discrete area in the office as a reminder. I would also recommend that you get it out every 6 months or so and just review it, update anything. If you ever feel like, maybe some parts of the team are not following the standards of care the way that you had hoped, now you have a document that you bring to the table that they were involved in, and you can say, hey, these are our agreements with regards to our standards of care. How can I help you uphold this? Or what is the obstacle that's getting in the way here? This could also be a part of your handbook, right, for your hygienist, and they're signing off that they understand these are the standards and this is, what's expected. But don't be afraid to have some dialogue around this, right? Don't be afraid to really bring them alongside you, to really look at this and have a good discussion around this, and really look at where are their beliefs and where are there some things maybe that you can help them really beef up. And then once you've established all of these things here, now it's time for your goals, right? Now is the time where you can really look at, okay, so based on the potential that we saw, what's a conservative goal for us for periotherapy per month, right? Compared to what we're doing now. How might this impact our hygiene production, and what are our goals there? What do we need to do with the schedule to support this, right? Are you in a position where there's no time for periotherapy on the schedule? That's a huge obstacle that we see very often. And I will tell you, as being a hygienist myself, is what happens is, even if the hygienist sees disease, right, and they think, gosh, well, even if I enrolled this patient in periotherapy, I can't even get them in for 8 weeks. So I'm just going to do the best I can right now, and then I'm going to check them again the next time. And that cycle is very difficult to break. So very often the schedule is one of the obstacles, right? Whether that is the amount of time that the hygienists have to do these diagnostic processes and to enroll the patient in treatment, right? So if that's an issue, figure out how to either they have support getting all of this data, or what are the expectations of what is completed in that appointment are really important to discuss. Or maybe it is, I just don't have time in my schedule once it is diagnosed. Then how do we put in blocks? How do we expand the capacity in hygiene to accommodate that? So this is another resource that I wanted to share with you, and there's a link to this as well in the resource guide. But this is an ebook that I was proud to be able to collaborate with some of these phenomenal other advisors and consultants in our industry. Some of them you may have heard speak at various conferences. A lot of great actionable data, checklists and guides in here, and the standard of care is here. There's also a really short little mini course, which is this video here that you'll get access to, which is really kind of about acknowledging and leading hygiene back into this level of optimal care through this dark time that we've been in here.